Hello, today we will be discussing a significant disease as we present to you the case study about the causative agent of post-streptococcal glomerulonephritis. Your presenters are Arandia, Jonamae, Bacudo, Jhanina, and Santiago, Jaira, and we are OLFU-QC interns of Jose B. Lingad Memorial General Hospital. For the case study content, in this presentation, we will be answering what is Group A Streptococcus pyogenes, what is post-streptococcal glomerulonephritis, the case brief summary, who is the patient, the symptoms of the patient's history, the clinical examination, and the results. This also includes pathophysiology, risk factors, laboratory diagnosis, treatment, control, and prevention. Now let's begin with what is Group A Streptococcus pyogenes. It is a gram-positive cocci in chains, aerotolerant bacteria, nephrogenic strains, and it produces enzymes called streptolysin. It also forms beta-hemolytin in blood aggregate. For the biochemical test, it is catalase negative, pyruvate positive. It is responsible for human infection, some of which can have a serious sequelae. M protein is the major virulence factors of Streptococcus pyogenes. Now, what is post-streptococcal glomerulonephritis? It is where kidneys glomeruli became inflamed after infection with Group A Streptococcus pyogenes. It is nephritic, involving a Group A beta-hemolytic Streptococcus infection of the skin or throat. It involves immune complex-mediated inflammation of the glomeruli 1 to 6 weeks after infection. The disease is usually mild and runs its course and resolves spontaneously within a month. Post-streptococcal glomerulonephritis is not a kidney infection caused by Group A Streptococcus. Rather, it is the outcome of the body's immune system attacking impetigo, scarlet fever, or strep throat. Meaning to say, it is the immune complexes that impairs the function of the kidney. Now let's proceed with the case brief summary by Santiago, Jaira.
Thank you, Ms. Arandia. Now we will proceed with the brief summary of our case study. Who is our patient? Our patient is an 8-year-old boy who experiences symptoms such as fever and lethargy for several days. He also complains with his backache and blood in urine. The patient's history involves severe sore throat with fever 3 weeks prior. He also receives medication such as aspirin and throat lozenges. For the clinical examination, his temperature is 39.8 degrees Celsius. There is an edema in hands and feet. For the CBC results, the RBC and platelet have normal values. However, the WBC has 13.2 times 10 raised to 9 per liter, which is above the normal values. Now let us proceed with the urinalysis results. The color is red, the protein is 3+, clarity is cloudy, while the blood is 4+. The pathogen is no longer present in the throat nor urine. The buildup of immune complexes due to past infection is the one that causes the disease. The rapid GAS antigen test is negative, while the streptolysin test is positive. This will be further elaborated later. For the pathophysiology, it involves pathogenesis and transmission. Humans are the only reservoir for Group A Streptococcus. The streptococcal antigen antibody complexes are deposited in the kidney's glomeruli. These immune complexes cause tissue damage and reduce kidney function by inducing an inflammatory response in the region. For the risk factors, children are the commonly involved or infected with this pathogen. There is an after-infection of skin, also known as impetigo, or the after-infection of throat, which is pharyngitis. The symptoms involves hematuria, proteinuria, and oliguria. There is a dark reddish urine, peripheral edema, periorbital edema, fluid buildup around orbit of the eye, and hypertension, as well as fatigue or mild anemia. For the transmission, the post-streptococcal glomerulonephritis is not contagious since it's an immune response. The group A streptococcus transmission may only occur through fomites, direct person-to-person transmission. Now let us move on to the laboratory diagnosis, which will be tackled by Jhanina Bacudo.
Post-streptococcal glomerulonephritis can be determined if the patient recently had a group A streptococcus infection. Through this laboratory diagnosis for detection of antibodies through extracellular antigen has developed. These include anti-streptolysin O, ASO titer, anti-DNase B test, and streptozyme test. First, the anti-streptolysin O ASO titer is a blood test to measure antibodies against streptolysin O, a substance produced by group A streptococcus bacteria. Its principle is neutralization. SLO is added to serial dilution of patient serum, along with group O RBCs as indicator cells. The ASO titer begins to increase approximately 7 days after infection and peaks after 4 to 6 weeks. ASO titer is reported as the reciprocal of highest dilution that shows no hemolysis and is expressed in Todd units. Normal values. Healthy adults have ASO titer of less than 166 Todd units, with the usual titer decreasing after 50 years of age. A 30% rise in titer above a previous level is of greater significance than a single titer. The anti-DNase B is a blood test to look for antibodies to a substance protein produced by group A streptococcus. When used together with the ASO titer test, more than 90% of past streptococcal infection can be correctly identified. The anti-deoxyribonuclease acid B test is a neutralization test that can demonstrate recent streptococcal infection. Anti-DNase B neutralizes the activity of DNase B. Next is streptozyme test. The streptozyme test is a screening test for the detection of antibodies to several of the extracellular antigens, including NADAs, DNase, hyaluronidase, streptokinase, and streptolysin. The test is rapid and simple to perform, but is much less reliable than the ASO and anti-DNase B test, which are preferred tests. The methodology is hemagglutination with agglutination of RBC representing positive result. Therefore, if the test is to be used at all, it should be used in conjunction with the ASO and anti-DNase B test, with the sequelae of group A streptococcal infection are suspected. Treatment is usually supportive and usually focuses on managing swelling and blood pressure. Treatment may include antibiotic like penicillin G, benzathine. The main way to prevent post-streptococcal glomerulonephritis is to prevent group A strep infection, like streptococcus throat, scarlet fever, and impetigo. Good hygiene is the best way to keep from getting or spreading group A streptococcus bacteria, is to wash your hands often. This is especially important after coughing or sneezing and before preparing foods or eating. And that's it for our case study. Thank you for listening.